All right, and we're back. So now we're going to talk about the management of cardiovascular emergencies. Um, most of you guys are again super proficient at doing this sort of deal. So we'll kind of breeze through it and move on with our days. All right, so the management of the cardiovascular emergency, particularly the cardiac arrest patient, I think anecdotally, we're finding more and more return of spontaneous circulation and discharges from the hospital. Now that the emphasis has changed to that, good quality CPR, easy or the most successful, accessible airway management versus just as paramedics, we were so locked in on doing the intubation that a lot of times the other good stuff or the other maybe more important management modalities were being left out, such as good chest compressions and just good basic bag valve mask ventilation. So, basic life support, right? It's the primary skill for managing the serious cardiovascular problems. Um, Neglecting that BLS procedure will it'll kill your patient, right? We talked previously in the assessment piece about obtaining a good, thorough history and assessment prior to initiating treatment, making sure we've got all the allergies and medications down, and that we have a good idea of that previous medical history. Um, and so we've done that good BLS survey. We've taken care of that primary or that initial assessment, and now we're moving into more of the advanced treatment. So the advanced life support, right? We're going to have ECG monitoring or EKG monitoring. We're going to most agencies out now. Most agencies are really in tune to the 12 lead EKG. A few agencies currently are doing the 15 lead. And a lot of times, especially in our brief management of patients, from point A to the hospital, we're not doing much more than just kind of the basic ACLS sort of guidelines, which is good because to a certain degree, being more proficient in a few things is better than being kind of good at a lot of things. So, ECG monitoring, right? We're always going to treat the patient, not the monitor. Compare the rhythm you see on the monitor with signs and symptoms, right? So just because it has that nice flat line on it that says they're dead, if they're up and talking to you, that's kind of that classic joke that runs around. Bagel maneuvers, we're going to use those to help slow the heart rate for a stable patient with symptomatic tachycardia, right? That really high heart rate. Again, you'll find that ACLS is saying that the SVTs and the ventricular tachycardias at 150 or higher are considered good indications for synchronized cardioversion, and but I think it's rare, from my own sample size of n equals 1, to find anything less than like 180, 200 to be symptomatic, right? A lot of times people manage really well with that 150, and then you kind of have to weigh advanced treatment on the scene with a fairly stable, with a stable patient, versus getting them to the hospital where they can kind of out-resource and really out-manage anything we can do in terms of taking care of a patient, a stable patient in that regard, or a moderate emergency. Let me back up real quick. Okay, so defibrillation, right? That's going to be the process of sending electrical current through like a fibrillating or a that VFib or that pulseless VTAC. And remember that it's that automaticity of the cell, right? It's kind of that slap to the system, that shock to the system, literally. Then it's going to allow the depolarize, repolarize uniformity, right? They're gonna get back in the business of making an organized rhythm. You guys are well versed, right? Two rhythms, ventricular fib or VFib, or pulseless VTAC. Synchronized cardioversion. It's going to be a controlled form of that defibrillation we're going to use for that unstable patient with the SVT or the VTAC. You've got a dysrhythmia that would be considered organized, still be considered some organized electrical activity. However, the difference with the cardioversion versus the defibrillation is the synchronization of the defibrillation or the shock on the R wave. And I know that the way those bullet points kind of march out is maybe a little bit confusing. So the dysrhythmias that are going to qualify for that synchronized cardioversion are going to be VTAC with a pulse, that PSVT, the uncontrolled atrial fibrillation, uncontrolled AFib, right, or that 2-to-1 atrial flutter. So we've got, let me back up one, right? So you got coming up, we got VTAC with a pulse, right? Then we have just a classic sort of SVT. Then an uncontrolled atrial fib, right? And for a lot of agencies, like if you were to see this, and again, everything has to do with the patient condition and complaint, right? If they're not complaining of, if they're not showing signs and symptoms of being unstable, you may choose to monitor, get them some oxygen, try to treat the underlying problem, and then get them to the hospital, versus, administering either synchronized cardioversion, or in the case of that SVT, or even that VTAC, some sort of dysrhythmic, right? So, or anti-dysrhythmic. So, like the adenocard, the adenosine, or the lidocaine, or amiodarone. So real quick, we're gonna kind of watch have two videos kind of inserted in here. Some folks have never done any synchronized cardioversion, never seen any synchronized cardioversion. So I'm gonna insert a couple of slides on management of that stuff, 2 videos, and then we'll pick back up and we'll talk a little bit about transcutaneous pacing. Okay, so enjoy.
How are you doing, man? Are you with us? Okay. We're going to keep talking to you until you're not with us.
I'm going to get ready to...
If we have to give you more, we'll give you more.
Here, I'll get another spoon.
How are you doing? Still with us a little?
I'm next. Dib's next.
Can I get some of this tonight? Just
How are you doing, man? Johnny.
Charge. All right. Charge it up. All right, clear?
yeah.
Sorry, man. You're done. All done.
Johnny?
Relax.
Johnny, how you feel?
Relax. See if he's not fully sedated. That was pretty sedated.
How many
did you
joules
do?
was that?
200.
That was.
Johnny? Hi, Johnny.
How you doing, man?
How are you?
What's the half-life on that?
Oh,
Short.
did
He'll
we-
be in 2 minutes. He'll be done.
Did we convert?
In the fucking ass. Wow.
He won't remember that.
What's his rate then?
Like 130. But if I shocked you right now, you'd be at 130.
Holy shit.
What do you remember? What do you remember?
Well, just wait 5 minutes. He won't remember.
He won't? Why is he remembering now?
He just thinks he's remembering right now.
He's dreaming.
Kick my fucking ass.
I don't think he was out.
He was
Was he?
He's not responding.
Yeah, we woke him up good.
You take that?
Oh yeah. Oh yeah.
That's totally against hospital.
I know. Don't try and
Can't
like.
even do that. It was his idea.
Yeah,
He's
it's
the
his
one
phone.
officer. Did it work?
Oh, it's his
Yeah.
phone?
Yeah.
Wow. That was a friggin'. Ooh.
How are you feeling?
You the man, Dr. Belly. You the man.
It's your thumb.
you don't mind having a video made of the treatment, even if it ends up on YouTube, and which a lot of times it does. So we'll be.
As long as they're in the course of it, hit somebody. No problem.
Yeah, these are important educational tools. So we've tried. Charlie, what have we done so far?
We tested 6 and 12 with adenosine. We did 24 along with vagal maneuvers here with no success.
No success. Okay.
All right, we're gonna sit you back, okay? All right.
It's gonna make you a little bit sleepy, okay?
Only years ago, I was, he made Other than that.
Okay. Now this is gonna be a little uncomfortable, okay? That's the nice way to put it. The real way to put it is it's gonna feel like somebody hit you in the chest with a baseball bat. Okay? And hopefully we wanna have to do this for once.
I spent a lot of time in the military.
Alright.
Versed?
How are you
Got it
feeling?
already, or you need it, or Versed? Just right now.
I'll give you 30 seconds.
Might need some,
Oh,
that's
yeah.
impressive.
Put this back on you, okay?
Okay, so you need the Versed, or you got the Versed? Got it already, okay.
Yep, sorry. Put this on. Alright, Charlie.
Do it now.
How are you feeling? Put this back on you here. Okay, curl it up, thank you. Okay? Okay. Alright, here it comes, sir.
Trying to. Okay, bud. You're doing good. Good, buddy.
You doing alright?
You working?
All right.
Okay.
All right.
Learn when a plan comes together, don't you? Cardio duty.
He was picking up 2 weeks of his back.
We didn't sedate him completely because of his low blood pressure.
Correct.
You doing okay, Mr.
Now
Baby?
our heart rate's holding. Cycle that pressure again after it's done, please.
Negative. 1/1/66.
Mr. Glenn, you're doing good, honey.
You doing all right?
Yeah.
Yeah.
You okay?
How you feeling?
You can relax.
Relax.
I know.
At
That's
least
that verse.
he's not gonna
Trying to
remember.
eat that pulse ox. Everybody likes to eat the pulse ox.
You're all right. All right,
All right, Charlie. What else do you want?
it's okay. You're doing good.
How you feel?
A little before and after. You doing okay? Good.
Relax back. It's okay.
Sorry about that, but problem's fixed, okay?
Now.
Just make sure that he hasn't infarcted. You have to make sure that there's nothing.
The electrolytes.
Electrolyte abnormality. You gotta make sure he's not infected. You gotta make sure. I mean, I don't think he's withdrawing because it's been 3 weeks. He's not well, he was a little hyperdynamic with heart rate, his blood pressure was fine. So
But
you
did
look
say
for
he'd
everything
been
else.
having a little bit of hallucinations, and
What now?
you did say he had had some hallucinations and been like this for 4 days, so maybe he's DT.
Yeah. So maybe.
He's
He
done
had
this-
next to where he was sitting a bucket about that full of vomit. Too.
Okay. Well, there you go. So you gotta work him up. You know, just search for everything. You know.
No, he's not.
And you know, look for his guidance 1.8. I don't know what it's based on.
Well, I must have done one now.
I'm
Yeah.
sorry, but
And then see if he's in there. Look for the old stuff. You know, pour. You know, give him some fluids. I would give him some Ativan now. I would give him some multivitamins. I'll give him some diamonds for like. You know, I'm not big on banana bags, but. And then just X-ray.
can you relax for just a minute? Put your arms down by your side.
Get one more EKG, honey.
But I think you know the back
You're doing
the back part
good.
now is
Can you
gone.
relax your arms?
That's pretty impressive heart rate.
All right, so we're back, right? So we're picking up with the transcutaneous pacing, or the external cardiac pacing. The first video, or that first shot of the the guy getting synchronized cardioversion is pretty funny. I guess I should have prefaced it with a little language alert. And then the second one, I thought what was interesting is the use of the cough medicine that actually made her condition worse, right? And that's ultimately what brought her in there. And that sometimes we run into those kind of issues with patients. So just a real quick blurb on TCP, or external cardiac pacing. It used to be something that we did a lot years ago, and now it's kind of lost its favor, and it's sort of recommended now it's used as a possibility in ACLS guidelines. So you would use it for that unstable patient with symptomatic bradycardia. We've probably already treated them with atropine, and tried to treat that underlying issue. And so now we've kind of moved to this. And so again, like if you haven't done this in a while, or you've never done it, it's one of those deals where you really need to become proficient in looking at and making sure that the pacing is actually being captured. And as always, refer to your local protocol and get with your medical director and or your supervisors and really figure out if this is the deal and this is the direction that you're going. Okay, so managing some specific cardiovascular type injuries. Right, so the first one is going to be that angina pectoris, or that chest pain. It's caused by lack of oxygen to the heart muscle, that myocardium, due to inadequate blood flow through the coronary arteries. It could be that atherosclerosis, or that Prince-Metal's angina, or that atypical angina, spasm of the coronary arteries. And interesting, some cardiologists say that there's kind of a real relation to that chest pain, especially in those younger men with that Prince-Metals, and that smokeless tobacco use. That smokeless tobacco use a lot of times kind of brings on that Prince-Metals, perhaps, especially if that patient's kind of predisposed anyway. So that's just something to kind of wedge back in the back of your melon to figure out if that may or may not be one of the causes with the patient that you're dealing with. Especially if it's an acute onset or a first-time onset and they're really not sure what's going on, other than it just feels horrible and they're calling you. Remember, there are two types of angina. There's the stable versus unstable, and the stable's going to occur during activity. So they're running, they're playing, they're doing some sort of activity, outside. The unstable is the patients at rest. Maybe they're watching TV and all of a sudden they start having chest pain. Some other causes of chest pain are going to be that pericarditis, or that inflammation around in the sac of the heart, or that pleural lining, or that lining. Respiratory problems, a pulmonary embolism, pneumothorax, pneumonia, pleurisy, right? All those things that are kind of revolving in that torso or that interthoracic space. Some other causes, and I'd mentioned earlier, like cholecystitis, that gallbladder problem. Pancreatitis, that hiatal hernia. This hiatal hernia and that GERD, that peptic ulcer, some of that stuff, you're going to find that patient when you go to their house. It kind of has an indication that they're having some problems. Maybe that, it looks like they sleep sitting up, right? They've got that respiratory problem. They've maybe got some, they've got either some hiatal hernia or that GERD, or maybe they've got COPD or CHF or something like that, and it looks like they live in the recliner, in that reclined position, and they haven't kind of laid down in bed in a very long time. Musculoskeletal problems, that costochondritis, shingles, and of course chest wall trauma. In managing the kind of classic chest pain, angina, or potential heart attack, there's just no way for us to tell. We need to definitely get them to the hospital, to definitive care, and we're always going to treat as if they are having a heart attack, because you never want it, right? We never want to take the chance that, maybe I made a mistake, maybe I misdiagnosed and missed something, maybe I was off my game just a little bit. I think it's, it's kind of we all know that not every day is like an A game day for us. We want it to be, but sometimes things are kind of going off, right? The public expects us to be that way, but occasionally we may miss a thing or two, and it happens. So we always want to get in the habit of doing kind of best practices. So for on those days when you're kind of maybe missing a sign or a symptom, you're just not quite sure, that we're just going to treat it like it's chest pain, right? If they say they're having chest pain, they're having a heart attack until it's ruled out at the hospital, right? Or unless we find something else. So for instance, having significant chest pain and you notice that they've got a lot of chest wall trauma or bruising, well, that may lead you to think that it's not cardiac, that it's actually musculoskeletal. But with the angina patient, doesn't matter. We're going to treat them as if they're having a heart attack. And remember that acute myocardial infarction or that myocardial infarction is the death of that thick, meaty part of the heart, right? So you got that endocardium, the outside layer of the heart, and then that myocardium, and it's going to be that lack of oxygen, that death of the muscle, and the size of that infarct and the vessels involved or the death of that tissue is going to depend on the size and location of the obstruction. There's basically two sort of classifications of an infarct. You got that MI that affects the full thickness of the myocardium almost always, right? So it can't almost, there are no absolutes, but almost, or most of the time, it's going to result in that pathological Q. So that baby box, the width is going to be greater than that 0.04 or one of those little baby boxes, and the depth of that R wave will be, or that Q will be the depth or greater than a quarter of the R wave. Okay. And then remember, in that R wave, it's going to be that first positive inflection after the Q wave. So the second one's going to be that subdenocardal, and that's an MI that only affects the deeper levels of the myocardium and usually doesn't result in that pathologic Q. Okay. So then you got that so the stages of that myocardial infarct, right? So even if it's a full occlusion, it's a process versus just bam, but the process can move very quickly. So you've got that myocardial ischemia, the tissue's not getting oxygen and all the other good stuff that it needs, those nutrients. There's some depolarization and contraction that's occurring, but that repolarization is not working really well, and so that's where you start seeing the depression of that T wave, or that ST segment, or the inversion of the T wave. With ischemia, just like a TIA, if we can, or any sort of ischemic event, if we can restore blood supply quickly enough, damage may be avoided. Okay, we may actually have full function back, but that's if it's caught quickly and treated quickly, and the treatment is effective very quickly. Then we got the myocardial injury, right? So there's actual injury. So it's capable of being saved. So think of this kind of in that bruised sort of idea, right? It's kind of like a bruise, right? So it's damaged, but it can heal, right? Or we can reperfuse or prevent that permanent damage if we reperfuse soon enough. So once it depolarizes, this tissue cannot repolarize. That means it's in that state of permanent depolarization, and this can be seen as that ST segment elevation. So the question is, right, and you see it, especially if you've been around for a while, that just because you see ST elevation, well, it's a great indicator, right? Unless we have something to compare it to, so if they had a previous heart attack, right, we can't just say, oh, that's from a previous heart attack. We're going to treat it as if that's a new onset until we have something either to compare it with, or we get them to the hospital, which is where the records are going to be. And above all other, even if we could compare it, we're still going to call it a heart attack and treat it like a heart attack, right? Because that's just good principles. And then so we go from ischemia to injury, and then that final piece is going to be the infarct, and that tissue's actually going to die. So it can't depolarize, it can't contract, And so if it's mural, it'll go like through the full thickness, right? And the Q wave will be seen, and that T wave will almost always be inverted. Okay. If it's subdenocardal, there's not going to be that Q wave, and the T wave, it may or may not be inverted. So that makes it almost as clear as mud, right? So a lot of times we're looking for those classic telltale signs on the EKG, but I guess the real take-home message here is like treat the patient, use the EKG as what it is. It's a tool, right? And like for most of us, we think as paramedics we get caught up in the minutia of stuff, right? Like, so we'll look at that 12 lead and we spend forever trying to figure out if there's a bundle branch block or we have an axis deviation, when we really just need to get them to the hospital, give them that nitro, that oxygen, and get moving, because a lot of times our protocols don't even allow us to do much beyond that. Okay, so that's just some stuff to think about, right? Like, be proficient in reading your EKGs, be proficient in analyzing a 12 lead, but don't get caught up in the madness and avoid doing good treatment. The management for this is pretty simple, and it's been like this for a real long time, right? Place the patient in a position of comfort, O2 IV monitor, Mona, not in this order, right? Morphine if the blood pressure is okay. Morphine's kind of taken a hit lately in the management of cardiovascular emergencies or cardiac emergencies. And kind of look that up on your own. There's a guy by the name of Corey Slovis who does some stuff, who's the manager of the emergency department at Vandy, and he in a presentation he brought up some ideas about how morphine is kind of getting looked at as not something to give in the emergent setting. Oxygen, high flow, right? Everybody gets high flow. American Heart says right between 4 to 6. That lower concentration, right? That 22 to 44 from 2 to 6 liters per minute via nasal cannula. The idea there is that kind of prolonged exposure to high concentrations of oxygen, like you would have in a non-rebreather, could cause coronary artery constriction, which can make the problem worse. However, in the emergent setting, that's not necessarily been proven true. So the evidence is still kind of out there on that. So, and again, the cop-out is follow your protocols or the ACLS guidelines, right? So the ACLS guidelines say 4 to 6. See what your protocols say. But again, remember that ACLS guideline is for more of a hospital setting. So anyway, just kind of just figure out what the best management is for you, I guess, is the rambling take-home message on that. The nitroglycerin, right, if their blood pressure's okay and they're not on any ED medications, and then aspirin if they're not specifically allergic to aspirin or have like aspirin-induced asthma, something like that. And remember that that aspirin is does nothing more than inhibit platelet aggregation or the platelets coming together. So it's not technically an anticoagulant. Okay, so just kind of think of those pieces. The management of continuing on the management of that MI or that AMI. Excuse me. There we go. If they're hypotensive, contact medical control before giving that fluid bolus or starting that dopamine drip. Always be prepared to treat those dysrhythmias. And, if a patient wants to NPC, we have to do our best measures to try to get them to change their mind. I mean, at that point, truly, we are like a car salesman. We want to sell them on the idea of getting to definitive care. When transporting, use lights and sirens only if it's absolutely necessary. So we're going to switch modes and head into heart failure land. So heart failure is going to be the heart's inability to mechanically perform, okay, so that the cardiac output doesn't meet the body's needs. There's two types, right? So there's left ventricular failure is going to cause that back pressure of blood into the pulmonary circulation. It's often seen as pulmonary edema. Some causes are MI, some valve disease, chronic hypertension, and dysrhythmias. And then there's right-sided failure. Right, it's going to cause back pressure of blood into the systemic circulation. Left ventricular failure, is the most common cause. Pulmonary hypertension, COPD, that cor pulmonale, right, or heart failure due to pulmonary disease, pulmonary embolism. And so with that congestive heart failure, right, the fluid is going to continue to overload the body's tissues, particularly in the lungs. And the chief complaint, right, usually is difficulty breathing. Labored breathing, fluids, sounds of fluid in the lungs on auscultation. You may actually hear it as you walk across the room. It's not that high vascular sound. It's they actually have it in their bases. You know that they are, you notice that they are sitting up. They're really working to breathe. You may see some wheezing, orthopnea for sure. They're not going to be able to lay flat. And peripheral edema or jugular vein distension, like if they're sitting up, they're having a hard time breathing, and you have pronounced jugular vein distension, there's, if it walks like a duck and it quacks like a duck, it's probably a duck or congestive heart failure, right? Coughing up that pink frothy sputum is another good indicator. And we're going to manage these folks. Position of comfort, O2 IV monitor. Don't overload them on fluids. And then we're going to give them those three main drugs, right? Some nitro to kind of vasodilate, make a bigger container. Lasix, which a lot of times we're not going to see the manifestation of the results. And then morphine to just kind of calm them down. Also, with that, we have to determine whether or not it's due to an underlying rhythm problem, right? So if they're kind of sinus tachycardia, which they probably will be due to the inability to move oxygen-rich blood through the body, we want to make sure that it's not because of some other dysrhythmia. So you may see some sinus tach kind of stuff, maybe some PVCs, but when you start seeing other sort of other dysrhythmias that aren't suggestive of just, hey, I'm going kind of into shock because I'm having a pump problem, then we need to treat that dysrhythmia. And CPAP or bag valve mask ventilation has made a huge difference in the outcome of these folks, right? So for years, the only possibility was either bag valve mask ventilation, which worked great if you sat the patient up and they could get with your program, or we kind of knocked them down and put a tube down their nose or a tube down their throat, and the results just weren't as good. So now with CPAP, these folks are becoming well aware of the program. They get in line and they manage it really well, and we see some really good outcomes. Cardiac tamponade is going to be that accumulation of excess fluid inside the pericardium. It's going to cause that heart to squeeze, so it's going to really prevent that good diastole and systole, and so it's going to decrease that stroke volume, which is ultimately going to decrease the cardiac output, right? So that, remember, we need to get that 70 milliliters, and if we're not getting at least that 70 milliliters relative to the patient's size, right, then it's going to decrease that cardiac output and over a minute, right, that minute volume, and it will lead to significant issues. And if that fluid continues to accumulate, we're going to see, you're going to see that patient slowly but surely have narrowing pulse pressures, difficulty breathing, altered mental status, and so on. So the way we're going to manage that is ABCs always, right? O2 IV monitor. Medications may be helpful. Got to be careful though. Lasix, morphine, and dopamine. Honestly, the big thing that's going to help them, right, is that pericardial synthesis. Hypertensive emergencies, life-threatening elevation of blood pressure, diastolic pressure greater than 130, associated with these signs, restlessness, confusion, blurred vision, nausea, vomiting, nosebleed, headache. So we're not really going to do a lot other than, and it depends on your protocol, right? Maybe your service is a little bit is very progressive in dealing with these, but for most agencies, especially in the Eastern Tennessee area or region, Position of comfort, O2 IV monitor, vital signs. Let the hospital manage the hypertension. Medical control may have you administer some nitro, Lasix, morphine, labetatol, something like that. But for the most part, you're just going to take them into the hospital. So cardiogenic shock is going to be the heart's inability to pump enough blood to perfuse adequately the tissues of the body. It's the most severe form of left ventricular failure, and the most common cause of that is going to be the MI, right, or the AMI. Tension pneumo can also cause it, as can the cardiac tamponade. Right, and in the tension pneumo and the cardiac tamponade, we're just not really able to get a good systole going, right? But pulse pressures start to narrow because of pressures on the heart, and we're really decreasing its ability to contract and then relax and get full filling. So the management of that cardiogenic shock, O2 IV monitor, treat the most common underlying problem, or treat the problem, most commonly that MI, and always remember to treat any problems with rate and rhythm first before you start throwing the fluids or giving them the pressors, and particularly dopamines used in the pre-hospital setting. Cardiac arrest, fortunately or unfortunately, you guys are getting really good at dealing with this. The downtime is going to be the time from the beginning of the cardiac arrest to the start of CPR, and a lot of times we don't know. Especially, with a frantic family member, we have no real idea. The total downtime is going to be from the beginning of the cardiac arrest to the time in the emergency department. And then resuscitation, that's just our efforts to return a pulse. Right? And remember that in cardiac arrest, our goal is to, one, have a return of spontaneous circulation. But while we're trying to obtain that, is to adequately perfuse the brain. Right? Because the brain's going to 4 to 6 minutes and it's pretty much toast, right, without oxygen. So the big goal is we want to adequately perfuse the brain, right? So if you get that, so we've done that, we've gotten a good return of spontaneous circulation, we have a spontaneous pulse, right? The patient may or may not be breathing, who knows, and the patient may or may not survive, but we got that return of spontaneous circulation, and we call true survival, or a save, as the patient being discharged from the hospital. Okay, so the management of that cardiac arrest patient, and again, you guys are very well versed in this. BLS is king, and then we're going to go to defibrillation, and then following our ACLS algorithms in terms of medication administration. If you're going to withhold resuscitations, and this is not an all-inclusive sort of piece, again, your best judgment, your best training, the protocols established by your service, and then of course whatever state protocols you're kind of functioning under as well. Obvious death, or it's obvious they're not going to survive, rigor mortis, postmortem lividity, so on and so forth. Blunt traumatic arrest when you arrive on the scene. Patient, really the patient's family, has a valid do not resuscitate order. Right, it's signed, it's in hand, and it's ready to be taken to the hospital. If the family, requests that no resuscitation be initiated, consult with medical control, and if there's a disagreement, start resuscitation. I think in cardiac arrest management, law enforcement is the most underutilized resource, that they can manage all the crowd control problems while you're managing your patient. So I'd like to urge you to consider having law enforcement go in with you. If you're going to terminate efforts or resuscitation efforts, follow your protocols, but some guidelines out there, like if you've been doing it for 25 minutes, CPR, following ACLS guidelines with ALS procedures, consider termination. Definitely contact medical control and get their blessing. And of course, as always, follow your local protocols. Except if the patient is under 18, right? Hypothermia or a cold water drowning, a drug overdose, or the patient is not in a systole, gonna work them, right? gonna work them unless you have direction otherwise. For that PVR or that peripheral vascular or PVD, peripheral vascular disease, right? You've got the atherosclerosis. That's progressive. It's degenerative in the arteries. That fatty buildup on the inside of the vessel leads to a buildup of plaque, causes tissue blockage, can cause aneurysms. There's that arteriosclerosis, that loss of elasticity and hardening, and that's just kind of failure of the system. Those two conditions can lead to aneurysms, or aneurysms can just be genetic, right? Or just for one other reason, right? You've got a hypertensive patients have been hypertensive for years, and eventually maybe those arterial walls are just like, gosh, I've had enough, right? They just get weak, either by defect or some other reason. Most of them, as it says there on the slide, result from the atherosclerosis and involve the aorta, and the big one is the AAA, right? The abdominal aortic aneurysm. And it's usually right above that bifurcation of the common iliac arteries. Signs and symptoms, right? Abdominal pain, back pain, tearing, shearing, most horrific pain in the belly, pain in between the shoulder blades, hypotension, and then that pulsating mass in the abdomen. The acute pulmonary embolism, it occurs when a clot, usually blood or fat, lodges in the pulmonary artery. It could be air. Predisposing factors, prolonged immobilization from illness, injury, etc. Atrial fibrillation, people are highly susceptible. They're usually on some sort of blood thinner, and they have to get their INR pulled on a regular basis. If they're not pretty consistent with that, bad history, bad results can kind of come their way. One of the things to remember is that an embolism is a moving thrombus, especially when it comes to clots, right? So a clot that's stationary is a thrombus, one that's moving is an embolism. So a couple of things on the one of the things that can be seen potentially on your 12 lead is this S1Q3T3. And you kind of see there, right? So it's the triad of an S wave in lead 1. So that it's the first downslope after the first upslope in the QRS. You see it in the two slides there. A Q wave in lead 3 and a T and T3 in lead 3, or a T wave inversion as an indication, but it's not absolute. Okay. It's not absolute. So, that's just one more thing to consider. Another point on the, for the signs and symptoms of that acute pulmonary embolism: difficulty breathing out of nowhere, sudden onset, you can't hear it, right? Have sharp chest pain, clear breath sounds, low or falling O2 sat, and these folks crash pretty quick. They're pale, they look like death. And so we have to be very proactive. You don't see these a lot, and so really be on your game in terms of management. And the management is get them to the hospital, high flow O2, and get ready to treat any sort of dysrhythmias up to and including cardiac arrest you may have to deal with en route to the hospital. All right, so this is going to conclude the cardiology or the cardiac portion, lecture portion of the class. Thank you for staying tuned. And
hey, Rocky, watch me pull a rabbit out of my hat.